Hello everyone. Today we are going to understand the post endodontic restorations. The topic is post and core. So in this topic we are going to learn about the post core. Okay. So first is the endodontically treated teeth usually undergo a considerable loss of tooth structure because of caries. Undergo considerable loss of tooth structure because of caries, iatrogenic loss, and also the excess cavity preparation. Okay. In this iatrogenic loss and also the excess cavity preparation, the fracture resistance of this teeth is also affected by amount of substance loss. Okay. So the restoration of endodontically treated tooth involves replacement of missing tooth structure along with protection of the remaining tooth. The remaining tooth structure is important in planning and executing the restoration of endodontically treated teeth. The factors which should be considered by the operator are the strategic position of the tooth in the arch, the occlusal load, which the following will be bearing, overall occlusal pattern, also the oral hygiene of the patient. To replace the missing tooth structure, the operator should decide whether the retention is to be achieved through root canals or the remaining tooth structure The achieving adequate retention and resistance features of final restoration is always challenging. Over the years, the various material and techniques have been developed to ensure the retention, resistance, and aesthetics of post-endodontic restorations. So, what will happen if effect of root canal treatment on the tooth? So, after the root canal treatment, tooth exhibits certain morphological physical changes such as loss of tooth structure. The tooth structure might have been lost prior to the treatment because of caries and fracture, etc. The endodontic procedures such as access cavity preparation or involuntary cutting during negotiating root canals also lead to the loss of the tooth structure. The bulk of remaining dentin is important since the strength of the tooth is proportional to it. As the bulk of the dentin is decreased, the stiffness of the tooth is decreased. It is established that even the conservative access cavity preparation decreases the stiffness of the tooth by 5%, whereas in class 2 preparation there is 40% loss of the stiffness. And in mesio-occlusodistal deprivation, the loss of the stiffness is 60%. Physical changes: it is believed that root canal treatment leads to the dehydration, consequently weakening the tooth. Then a few authors, however, do not favor this notion, claiming that the dentin hardness is not altered after the endodontic treatment. The loss of moisture content from the dentin may lead to loss of translucency of the tooth. The altered appearance: the root canal treated tooth may show altered appearance because of presence of residual pulp remnants and even medicaments. The chemically altered dentin reflects light differently, which modifies the overall appearance of the tooth. Proprioception. Proprioception. Sense of proprioception is lost in the root canal treated teeth. Neurosensory feedback mechanism is impaired because of loss of pulpal tissue. Decrease in mechanoreceptive feature may lead to inadvertent biting on the non-vital teeth, subsequently fracture of the tooth. Post-endodontic changes: 10% reduction of the collagen bonded water, aging of collagen, changes in cross-linking. Then not much change happens in modulus of elasticity and dentin hardness and fracture resistance. Planning of post-endodontic restoration. The restoration of endodontically treated teeth is planned following the guidelines as the root canal treatment should be good quality. Only clinical asymptomatic feature will not be sufficient. So radiological assessment is mandatory. However, computer-aided radiography is preferred in evaluating the quality of observation. The common notion that endodontically treated fracture easily because of increased brittleness may not be correct. The amount of remaining tooth structure control the fracture resistance of the tooth. The operator should take extra care so that the loss of the tooth structure during the root canal preparation and tooth preparation be minimized. The root canal treated with, with sufficient amount of dentin can be restored without the need of extra retentive devices. The root canal treated with sufficient amount of dentin can be restored without the need of extra retentive devices. The reinforcement of the remaining tooth structure with bonded materials can also be planned. The long-term validity of this reinforcement if the time is questionable. However, the treatment is effective in the teeth with less surface area remaining, like premolars. And the operator should analyze all the factors placing post, especially in the posterior teeth. The post in posterior teeth is avoided as far as possible. Then the post is placed only to retain the core. A few authors are of the view that the post and core should be of same material. It minimizes the vertical stresses and is also time saving. Same material. It minimizes vertical stresses and also the time saving. The length of the post depends on the configuration of the core required of the length of the root. The amount of stresses which destabilize the restoration should be considered. The amount of stresses which destabilizes the root restoration should be considered. The removal of gutta archa always disturb the apical seal. Then early or delayed removal of gutta percha might not be significant in disturbing the apical seal. However, early removal is preferred. Then quick removal of gutta percha at the predetermined length with heated instrument is considered a better method. Suction of restoration for endodontically treated teeth. The primary aim of post-endodontic restoration is to protect the remaining tooth tissue, maintaining the occlusal function and aesthetics of the replaced tooth tissue. The amount of remaining tooth structure before and after the tooth preparation is important for the long-term success. Failure of the restoration. The remaining coronal tooth structure after the tooth preparation must be analyzed thoroughly and recorded. Prior to restoration of these teeth, the decision is to be taken whether the support from the root is required or not. The aims of post-endodontic restoration: replacement of missing tooth structure, then protection of remaining tooth structure, then maintenance of occlusal function and aesthetics. The silent features of this record are: the remaining dentin volume is calculated either by scanning the cast using a laser pro profilometer or weighing the remaining diastone and calculating the equivalent dentin volume. Since the volume of remaining dentin may not reflect the strategic contribution of dentin, it became apparent that an index assessing the remaining dentin would be useful. Tooth restorability index. What is tooth restorability index? It is also called as TRI. It was developed to provide the structured assessment during the defined parameter to evaluate the remaining coronal tissue. The tooth is divided into 6 equal sections, 2 proximal to buccal and 2 lingual area. TRI allows scores 0 to 3 in each tooth section with a maximum scores of 18 per tooth. Then the contribution of each tooth section remaining uh, then contribution of the each tooth section remaining dentin to retention and resistance form can be recorded following the score. The experienced clinician, 3 or more, can evaluate the cast regarding the remaining dentin. A scoring system of 0 to 3 was allocated to each section. 0 is none. Throughout the tooth head or more of the tooth extents under consideration, there is no axial wall of dentin, a box or missing cusp, or any dentin present above the finishing line is so lacking in height that may not be able to contribute to retention and resistance form. Then the score of is appropriate where a margin is visible just apical to the limit of the missing wall, but there is only a small bevel or chamfer comprising the preparation dentin. One is inadequate. The coronal dentin is present in the tooth section, but in terms of thickness, the height or configuration inadequate. Coronal dentin is present in the tooth section, but in terms of thickness, height, or configuration, for example, an undercut that is insufficient to make any predictable contribution to retention and resistance form as opened by the operator. Dentin wall less than 1.5 mm thick or more than twice as high as their thinnest part would be included in this category. Then 2 is questionable. Questionable more dentin is present than in 1, but clinically it will not make a predictable contribution to retention and resistance. This score should only be assigned where the operator find it difficult to determine whether the score 1 or 3 is more appropriate. Then 3 is adequate. There is sufficient coronal dentin in terms of height, thickness, and operator should confident that the distribution of forces would provide the requisite resistance and retention form to the final restoration. Although tooth restorability index helps deciding the type of the restoration for endodontically treated teeth, there is no definite consensus regarding the choice of the final restoration. The brittle nature of the endodontically treated teeth and also the lack of the moisture in these teeth have been disproved. It is established that the thickness of the residual dentin wall and cusp are the key factor as cavity size increases and the marginal ridge are lost. The structure durability decreases. For this reason, only the full coverage crowns are preferred in such teeth. So otherwise, if the structural durability is sufficient, alternatives such as covering functional curves, the bonded restoration, and pinlays can be planned. Composite crown, which need less tooth reduction, are also used these days. Cusp covering with indirect composite restoration is also effective. Then key features in decision making. Consider the structural durability and aesthetics amount of the available dentin thickness and after removing the caries, restorative material, etc. The remaining tooth structure, ability to retain the core, and for full coverage frowns make balance between the aesthetics and occlusal load. The patient's consent before finalizing the restoration. A classification is proposed which guides the choice of restoration in endodontically treated teeth. Classification is proposed which guides the choice of restoration in double retrieve. Type 1 is more than half of the tooth structure is present. Then type 2 is less than half of the tooth structure present. Type 3 is coronal tooth structure absent or minimum, and type 4 is root embedded. More than half of the tooth structure is present. Type 2 less than half of the tooth structure is present. Type 3 is coronal tooth structure absent or minimum. Type 4 is root is embedded. Now flowchart 22.2 depicts protocol for of selecting restoration for endodontically treated teeth. The selection of post-core restoration or only coronal filling depends upon the remaining walls. Tooth is considered to have 5 walls: buccal, lingual, mesial, and distal and occlusal. Then tooth to receive the restoration should be evaluated thoroughly before initiating restorative procedures. The features evaluated are the endodontic. The tooth should be asymptomatic, properly root canal treated, and filled with appropriate coronal restorative material, partially filled with root canals, and may not be symptomatic free. May not be symptom free. Should not be restored with permanent restoration. Session should be evaluated thoroughly before initiating the restorative procedure. The endodontic tooth should be asymptomatic, properly root canal treated, and filled with the appropriate coronal restorative material. Partially filled with partially filled root canals may or may not be symptom free. Should not be restored with the permanent restoration. Then periodontal. The tooth should be stable in the arch and also be able to withstand masticatory functional forces. The crown root ratio should be favorable. Then restorative. The position of the tooth in the arch and also the strategic value should be evaluated before initiating and definitive restorations. Classification guiding the choice of restoration. Root canal treated teeth. Type 1 is total or more than half of tooth structure remaining. Restore only access cavity, internal bleaching if need be, uh, full crown or aesthetic full crown function. Then root root canal treated type 2 less than half of the tooth structure bonded restoration amalgam composite or full crown unless covering weak or functional curves. Then post if remaining tooth structure is weak. Then type 3 is coronal portion missing or bare minimum. It should be followed by post and core followed by full crown. And type 4 is embedded roots, crown lengthening or orthodontic extrusion. Then post core followed by full crown. Protocol of selecting restoration for endodontically treated teeth. One wall missing only for access cavity. Uh, Treatment is fill access cavity, missing wall, no need to post. Two walls are missing, then full coronal cavity, coronal preparation, full crown, core preparation, and full crown coverage. Then three walls missing and a need of post. Then select post followed by coronal coverage, coronal coverage. Then four wall missing are need of post. Crown lengthening orthodontic extrusion may require and final coronal coverage. Then endodontic evaluation, faculty obturation and incomplete obturation, faulty obturation and incomplete obturation or incomplete obturation. Then periodontal evaluation, insufficient bone support, insufficient crown root ratio. Then respiratory evaluation, poor coronal restoration and position of the tooth in the arch, poor coronal restoration and position of the tooth in the arch. Post-core restoration, the substitution of the crown portion with or without help of pins is referred to as the core. The root canal support of the core may be metallic or any other material is referred to as the post or dowel. Collectively, the system is known as post and core or post core system. The resistance and retention form is preferably achieved mm, from the core only without the root canal support. In the case the post is mandatory. Post or dowel Post dowel is mandatory. The roots should be thoroughly assessed before initiating the post preparation. The root canal should be assessed for following features: remaining coronal incisal tooth structure present along the root, the quantum of occlusal load which is restored in tooth will be bearing, and configuration of the root canal, thickness of the dentin around the root canal. Then amount of dentin which can be utilized in preparation of post, number of root canals required for post replacement, then caries resorption inside the root. If any periodontal bone is support of the root, possibility of the extra retentive devices if any sufficient length of the post, which can be achieved from the root canal. The functions of post. Post serves the following functions. It retains core, which helps in reinforcement of the lost tooth structure. It raises the tensile forces, which tend to pull the restoration away from the tooth. It distributes occlusal force along the length of the root to the periodontium. Then crowns of endodontically treated teeth are usually damaged to an extent that the remaining tooth structure cannot contribute the forces along the natural ways. Then it remains the marginal integrity of the final restoration by providing the sufficient rigidity at the margins and prevents the breakdown of the cement medium at the tooth restoration interface. The function of the post are post serves as a retain core which helps in reinforcement of the loss of tooth structure. It raises the tensile forces which tend to pull the restoration away from the tooth. It describes the occlusal forces along the length of the root or to the periodontium. Crowns of endodontically treated teeth are usually damaged to an extent that the remaining tooth structure cannot distribute the force along the natural ways. It remains the marginal integrity of the final restoration by providing the sufficient rigidity at the margin, prevent breakdown of the cement medium and the at the tooth restoration interface. Classification of posts. The posts are classified as the self-retentive metal post with self-cutting thread and different types of screws. Then class 2 is metal post with passive retention, no direct contact between the post and root canal wall. The post needs luting cement for the space present between the post and root canal wall. Then class 3 is non-metal post with passive retention, fiber reinforced post and ceramic post along with the adhesive cement. Then class 4 is the biological post, dentin post along with the adhesive cement. The fiber posts also have been categorized as the generation based on radio opacity and their aesthetic appearance. The categorized generations are the generation 1 neither radio opaque nor aesthetic. Then composite post in mid 19C post are in generation 2 aesthetic but not radio opaque. Um, those are aesthetic but not radio opaque. The aesthetic plus light post, then fiber white, then fiber core, lucent anchor. Then in generation 3, aesthetic and radio opaque after the 2001 onwards, the DT light post illusion, then snow post and relay X post, FRC post take plus. Then types of post. Metal post. First is metal post, custom cast metal post, prefabricated metal post. Passive post are tapered, smooth or serrated. Second is parallel, smooth or serrated. Active post is tapered, self-threaded and parallel self-threaded. Fiber posts are the custom fiber post, prefabricated fiber post, carbon fibers, Mirafit carbon endo post, then carbonate system, CF post, and silica fibers. The quartz fibers aesthetic post, aesthetic plus, tile post, and light DT post. Then glass fibers are the snow post, Mirafit white, lucent anchor. Then fiber core post, fiber white para post. And polyethylene fibers are the ribbon THM. Then construct, then fiber post with gatta parcha, fiber fill post system. All ceramic post type 3 are the then type 3 is all ceramic post, type 4 is dentin post, biological post, type 5 is miscellaneous post system, 2 post custom post, split cast metal post and core, then post inlay system, then intraradicular rehabilitation with light transmitting plastic post. With light transmitting plastic post, the metal post can be custom cast and also be available as a prefabricated metal post. Custom cast for metal post, metal post are prefabricated from negative reproduction of the prepared root canal. Then the impression is made of prepared post face using wax or cold Cure resins, referred to as pattern. The pattern is invested in the cast, is prepared using the appropriate alloy. Type 3 and Type 4 gold alloy are preferred alloy. However, the base metal and titanium alloys are also being used. The custom cast posts conform to configuration of the prepared canal. The custom cast metal posts are prepared in a single rooted teeth. Indications are the teeth with elliptical flared canals, then teeth where alignment of the proposed crown is significantly different from the inclination of the canal, mostly in anterior teeth. Then availability of the adequate space or bulk of the build-up material around the post. When multiple teeth require post, it is advisable to make an impression and fabricate the post in laboratory rather to build in clinic. Advantages are the conform to the root canal configuration, usually tapering. Strong core is an inherent part of the post, provided stability. The core can be fabricated at different angle if need be more effective in single rooted teeth. Do not induce any stress during the installation. Disadvantages may act as a wedge during the full load. काय मास्तर काय म्हणता नाही वाचत आहो वाचू
काय सांग आम्हाला करू दे आम्ही काही आमचंही फायदा होईल आमची